So, good morning. I think Professor Spianova already introduced me, so we can go to the first slide. And we start, that was our starting point on the left. So it was an article published by Professor Peacock a few years ago. And he showed how a positive test for conventional troponin correlated with a higher in-hospital mortality in patients with acute heart failure. In the same paper, they also showed how there seemed to be a correlation between a positive test for troponin and a reduced ejection fraction. On the right, you'll see a more recent article where they've used high-sensitivity cardiac troponin in patients with chronic heart failure, and they found that a higher concentration of cardiac troponins are associated with a higher left ventricular mass and preserved ejection fraction. So since we couldn't find any consensus in the literature, we decided to set this study with this as our primary goal, so to evaluate the relationship between high-sensitivity troponin and the left ventricle ejection fraction in patients with acute heart failure and with their final disposition from the emergency department. Okay, so this is our study design. First of all, it's a retrospective study where we included all those patients admitting to the emergency department with a final diagnosis of acute heart failure from the beginning of this year until April. And of course, they needed to have a final diagnosis of acute heart failure. They needed to have a cardiac ultrasound evaluation in the emergency department, and of course, a high sensitivity troponin determination. We had to exclude all those patients with acute coronary syndrome, of course, based on the clinical evaluation, so history, physical, EKG, and troponin. On the right, you'll see the data that we gained about our cohort, and below the 5 hospitals in Rome where we did the enrollment. Okay, so we managed to enroll 376 patients. These are their phenotypes at presentation according to the more recent guidelines. And as you can see, more than 80% were admitted with acute decompensated heart failure and second counts pulmonary edema. We found that they are all equally distributed regardless the left ventricular ejection fraction and the high sensitivity cardiac troponin. On the right, you'll find the distribution of our cohort across the 5 hospitals, and below the final disposition from the emergency department. So only 10% were discharged, and then again, more than 90% had to be admitted. Of those, 65% in a low-intensity ward, such as cardiology, pneumology, or internal medicine, 12% in a sub-intensive care unit, and 10% in the ICU. We will focus here just on some data. So as already described in the literature, male patients and younger patients tend to have a reduced ejection fraction and a lower systolic pressure. Then below, the BNP levels are highly affected by the ventricular function. And finally, the cardiac troponin, well, we couldn't find any difference across the 3 cohorts in the mean value. We also gained some data about the right ventricle overload, and we estimated it as having an inferior vena cava of more than 20 millimeters, or if it was non-collapsible, and we found it significantly different across the 3 cohorts, so a reduced ejection fraction correlates with a right ventricle overload, but it doesn't correlate with a positive test for cardiac troponin. And below, the wet lung at presentation evaluated either through lung ultrasound or chest X-ray, and it was equally distributed in the 3 subgroups. So again, what we found basically is that 2/3 of our patients had a positive test for cardiac troponin, but again, there was no difference across the subgroups. So we might think that the high sensitivity cardiac troponin remain a reliable biomarker of myocardial injury, regardless the ejection fraction in the acute setting. And below, you'll find the final disposition correlating with the average high sensitivity cardiac troponin I, and of course, a high value of troponin at admission correlate with a final disposition to a higher level of care. Of course, this study has several limitations. First of all, it's a retrospective analysis without a follow-up, so we couldn't make a proper risk stratification. There are some confounding factors because of the etiologies of the acute heart failure, and finally, we lack some data about medical condition and the use of any medications. So to conclude, we can say that while the BNP levels are highly affected by the ventricular function, troponin seems to be independent from it, and therefore they should remain a reliable biomarker of myocardial injury in the acute heart failure without coronary syndrome. Of course, a prospective study will be needed in order to find if a simultaneous cardiac ultrasound evaluation and troponin determination in the emergency department can be integrated for a more appropriate risk stratification in patients with acute heart failure. And that's what we plan to do next. So a prospective study with an actual follow-up, and maybe also divide patients on the basis of the acute heart failure etiology. Thank you.
So again, many thanks for your presentation and interesting data, and also you were in the time limit, and again, the paper is open for discussion.
Thank you for a great presentation, very interesting subject. I have two questions, sorry. So first one is, you said that you included patients that had a troponin. It's not that routine in your service that troponin is
well, it
collected
on the
for
presentation,
all patients with acute heart failure?
Yeah, we do that. We don't do the ultrasound evaluation. So, of course, those 375 patients weren't all the patients admitting with heart failure, so just a few fraction had a cardiac evaluation.
And the second question is, how exactly did you classify the acute coronary syndrome? Because sometimes it's hard, it's a gray zone, if the acute heart syndrome is the trigger for the acute heart failure or not.
It's not.
So did you take this information for the chart retrospectively, or did someone adjudicated these charts to be sure that the patients really didn't have?
No, we did a review of the charts after, but most of these patients have been evaluated by a cardiologist in the emergency department, so the coronary syndrome was excluded by a specialist in the emergency department, so before the enrollment.
Thank you for the wonderful presentation. Actually, the ejection fraction is very good to assess the LV systolic function. But in this case, in chronic heart failure, ejection fraction is always low. But sometimes E over E prime or filling pressure is high. Sometimes it is not. So for the evaluation, I think instead of ejection fraction, we should check the E over E prime or at least filling pressure and correlate it with HSTNI. And also in case of RV overload, you said it's a pressure overload, I think, and it's not volume overload. And the IVC and the inspiratory collapse is not enough. And adding TRV max and RVSP is much more accurate. So in this study, I just meant comment, not ejection fraction, E over E prime and RVSP kind of more sensitive, more vulnerable to change according to the acute condition. It's much more well correlated with HSTNI.
We tried to make it as simple as possible because you always have like 30 seconds to evaluate the patient, so we will have to look into that, of course, but yeah, we have to see how fast we are in doing the evaluation.
Yeah. So, yes, this was more commentary from the audience. Yeah. And I just wanted to ask you how you were evaluating the right ventricle.
Just through the inferior vena cava evaluation.
Yes.
So we couldn't make a proper estimation of, I don't know, if it's abs or...
Yes.
No, of course.
Thank you. So, no more questions. So again, thank you for the presentation.